All right, guys, well, welcome back to the next video. Sorry it took so long to upload this, but it's been a pretty crazy here on my life recently. But again, as promised, we covered anti-cholinergic toxidrome last time. So now we're gonna go ahead and cover cholinergic toxidrome. I'm gonna discuss some of the basic presentation that you would see in a patient, some of the pathophys, and then also the treatment as well. So let's go ahead and get into it. First of all, it's very important just to understand how this would present, okay? And I drew this image myself here, right on the left. And this, in my opinion, gives a pretty basic description of what you'd see in cholinergic toxidrome. And basically, there's a lot of different mnemonics out there to remember. There's dumbbells, sludge, and then the 3 Bs. But basically, I would just remember that if you have an orifice, there's gonna be a fluid coming out of it. As gross as that sounds, that's the best way to remember it. So if you look at the little drawing I made on the left there, this patient is sweating. They're having emesis or they're vomiting, having lacrimation, and then they are defecating and urinating. And then also, if you can see there, I drew like little pinpoint pupils. That's just to represent meiosis. And again, meiosis is gonna be that pinpoint pupil. So again, you can pause the video and look through these, but again, I've covered it here: dumbbells, sludge, and then the 3 Bs. But again, I think a very simplistic way to really understand this is just to think that if you see a patient who's vomiting, diaphoretic, peeing and pooping on themselves, then chances are this is very likely going to be a cholinergic toxidrome picture. Now that we've covered what a basic kind of presentation looked like, why don't we go ahead and look at some of the mechanisms that cause cholinergic toxidrome and then some of the treatments as well. You may remember this drawing from last time, but this kind of gives you a basic understanding of some of the pathophys of cholinergic toxidrome. So if you remember correctly, with anti-cholinergic toxidrome, there was not enough acetylcholine making it from the a presynaptic neuron to the postsynaptic neuron. Now, in the instance of cholinergic toxidrome, there's too much acetylcholine, making it from the pre to the post, right? So there's too much acetylcholine, and that's leading to those symptoms that we discussed earlier. First of all, let's kind of figure out what some of the causes of cholinergic toxidrome would be. And one of the biggest ones, and I'm gonna go ahead and write that out for you, is gonna be organophosphate poisoning. All right, now, organophosphates, this is something you generally see, for example, a patient who's maybe a farmer or someone who is tending to various plants and things of that nature. But essentially, what organophosphates do is they irreversibly bind acetylcholinesterase. Let's go ahead and zoom in and I'll show you what that means. All right, so the organophosphate is knocking out acetylcholinesterase. And then you can see how if you've knocked out your acetylcholinesterase, you're not able to chew up as much of that excess acetylcholine, so you're gonna get way more acetylcholine moving from the pre to the postsynaptic neuron, which is gonna lead to those signs and symptoms, again, that we kind of discussed earlier. The next question is, what exactly is going to be the treatment for this? And really, it's kind of broken up into 2 parts. Okay, so one of the first treatment modalities is you're gonna use a medication called atropine, and I'll go ahead and write that out for you. Now, what atropine does, it is a competitive agonist at the muscarinic sites on the postsynaptic neuron. So let me go ahead and explain what that means in a kind of closer view here. Your atropine is essentially, here's our little orange dots are atropine. What they are doing is they're going to the postsynaptic neuron and they're basically blocking out these sites, all right? And that would make sense because again, you're getting too much acetylcholine, so you need something to kind of say, hey, let's chill out a little bit with this. All right, and that is exactly what atropine does there. Now there is something else, another medication you can give that also helps with cholinergic toxidrome, and the name of that medication is prilidoxime. And I went ahead and drew that in the green there. Now what prilidoxime does is that regenerates acetylcholinesterase, right? So basically what it does, think of our, remember in our purple here, the organophosphates that knocked out our acetylcholinesterase, but with prilidoxime, you are building more, and then those can go around and again start chewing up some of those acetylcholine molecules. So again, prilidoxime just essentially regenerates acetylcholinesterase, gets it back in the game, and makes it possible for acetylcholinesterase to chew down some of that extra acetylcholine. And then the last part I want to discuss here is that there's a different scenario where someone can be experiencing cholinergic toxidrome from something called carbamates. And there's a distinction between carbamates and organophosphates in that prilidoxime is not an effective treatment modality and it's actually contraindicated. We're gonna move on to the next part and I'm just gonna explain why that is the case. So here really quick, we have our 2 little blue acetylcholinesterase molecules. And this is just gonna help demonstrate why pralidoxime is effective with organophosphates but not carbamate. So let's look at our first example here on the left. This is going to represent organophosphate. So organophosphate, we'll say it binds, let's say there's two sites. There's a site here and a site here, right? So organophosphates bind here, essentially deactivating acetylcholinesterase. Pralidoxime binds on the other site, and what that does is it essentially rejuvenates that acetylcholinesterase. So boom, works there, fantastic. Now with carbamates, carbamates bind to both sites. So what can happen then, you give pralidoxime, but it has nowhere to function. And as a matter of fact, if there are any open acetylcholinesterase, pralidoxime will bind to those sites and it'll make the acetylcholinesterase function a little bit less efficiently. Let me explain. So you have pralidoxime, which is represented in that yellow. So it can't access the sites where the carbamates are bound to, but what it can do is it'll move to the sites of acetylcholinesterase that are unaffected by the carbamates, and it'll bind them and make them weaker, okay? But with organophosphates, yes, you can still have open acetylcholinesterase that are bound with that pralidoxime, but what happens with organophosphates is that when pralidoxime binds that open site affected by organophosphate is that it actually makes it function well enough that even though some aren't working properly, overall, it's a net win in helping take care of that cholinergic toxidrome. Well, hey guys, that's all I have for you today. I hope that was helpful. Again, like the video, comment, subscribe. And again, if there's anything else you would like to see me make a video on, please let me know. In the meantime, I'll just keep making videos on topics that interest me. All right, thanks guys.